start the echocardiography, one should know the history of the patients. Of course, physical examination to look for any kind of murmur or anything which you are predicting to be present, and look for the echo. And any previous investigation will give you a rough idea that what are you going to look for. And of course, the position of the patient. Make the patient very comfortable lying on the bed. Left decubitus position is very good and friendly for the echo. So as I told you that the pulse wave and the continuous wave has this difference. It can locate the origin of the velocity which is coming from here. And the continuous Doppler, there is a two type of crystals available in the present in the probe. One is sending the wave and the other is receiving the same time. It tells us that there is some problem is going on over here, but cannot locate the origin of the problem. There is a transducer. When we are doing the Doppler, the angle is very important to the tissue. It should be not at the 90 degree. It should be parallel to the origin of the flow which we are going to look for, because there is an angle between the probe and the tissue which is the cosine. Cosine of 0 is equal to 1 and cosine of a 90 degree is equal to 0. If we put the probe across the tissue which we are looking for, so we will never be able to get the real velocity of the blood or whatever structure you are looking for. So the angle between the Doppler ultrasound, which mode you are using, it doesn't matter, but should be parallel to the velocity. For example, this is an echocardiographic image, and this is the LV and this is the aortic wall. Well, so this if we want to look for any flow across this aortic route, so the spectral Doppler will be perpendicular in 90 degree to this tissue. It means it will never tell us the exact amount and the speed of this velocity across the valve. So we have to move the angle and make another view. Now there is a left ventricle and its aortic valve. So now our spectral Doppler is parallel to this line. Now it is able to tell us about the speed and the velocity of the blood or either regurgitant volume. So this is very important point to make it very clear. This angle is very important, and sometimes we overestimate and underestimate the velocity of the structures by not making the proper angle. So M mode, as I mentioned earlier, it is, for example, it tells us the amount and the velocity which the structure which are moving very fast, and we are unable to look and say that how far these structures are moving in the heart. So we just put M mode across the leaflets, for example, and we are looking just this straight line, and it will give us this picture. Now you can see that this is the left ventricle and this is the left atrium, and here is the mitral valve. So we put this line across the mitral valve leaflet, and this mode will show us the movement of mitral valve leaflets toward the septum. So this is the septum, and this is the movement of the mitral valve toward the septum, which can be very good and very excellent mode for the sonographer, and it will make us to look for any abnormal motion of the valve. And of course the SAM, we can look for the SAM in this mode. We can estimate the ejection fraction in this mode. So it's very friendly and it's a very good mode. So before moving onward, so there are some basic cardiac windows which we have to make before obtaining our interpretations, making interpretations of the patients, and looking for all these things which I have discussed here. So standard cardiac views for the transthoracic view, there is a bunch of views, but we use basically 4 to 5 views. I will explain these views very briefly, and it's very common using around the world. We are not here to discuss the advanced cardiography, so this is why I'm skipping these all the views. So just the basic views will be covered. Of course, for the transesophageal, there's also many views, and we will use very specific. So for the transthoracic echocardiography, we generally look for the parasternal long axis, parasternal short axis, apical 4-chamber, and subcostal. Of course, there is apical 2-chamber view as well, and of course there is a inferior vena cava view, and all others view are available. And so for us, we will discover these views and how to make it, and we will also have hand-on practice after the class. So for the T, we use the mid-esophageal 4-chamber, left ventricle long axis, and of course bicaval and transgastric short axis view. The difference between the T and transthoracic is this, because we are very far away from the transthoracic to look for the structures, but on the T we are very close. But there is one difference in the image. The images in the T and the transthoracics are mirror of each other, because we are looking from the inferior of the heart in the T, and we are looking in front of the heart from the transthoracics. So the image which is going to be produced on the echocardiography, this will be mirror of each other. So whenever you are making any diagnosis or a thing, so you should have in mind that if you are using the T, you are looking posterior of the heart, and especially it is very important for the abnormal wall motion abnormalities, because you are looking to different territory of the heart. So you should be aware of that the images of the T and transthoracics are mirror of each other. So we have a sequence, and this sequence is very useful. We start the echocardiography from the long axis of the parasternal, then we rotate our probe to go toward the parasternal short axis, and then we change the probe going toward the apical 4-chamber, and then the subxiphoid. So first of all, parasternal long axis view is made. Every probe has a marker, which is called cardiac marker or probe marker. The marker should be placed toward the right shoulder of the patient, and the probe should be placed between second or third intercostal space. This position will give us the long axis parasternal view, and it will look like this. In this view, we will be able, our probe is here, so first of all we are looking for the right ventricle. It's actually the right ventricular output tract. This is the LV, this is the aortic valve, and this is the LA, and this is the mitral valve. If you notice here, there is a echogenicity over here, and it is the descending aorta, which is very important to rule out and look for the pericardial effusions, which I will explain later on. So in this view, we very friendly view, and we can measure our sonographers which are doing echocardiography downstairs there in room number 9. I have visited there and I have seen them. They are measuring the structures over there in this view. They tell us the RV measuring in this view, of course the aortic root like this way, and the LA in the same way. They are measuring in this way all these structures, which are giving us the report. So in this view, actually this is schematic pattern, and we see all these structures that I have told you already. So this is the actually if you see, the heart is like present like in the cone shape of this. In this view, this is the apex, this is the base, and you see the anterior of the heart, and there is the posterior portions. This is the LV, RV, aortic valve, mitral valve, left atrium, and this is the interventricular septum. We can measure the interventricular septum in this view, which is very important, especially should be measured in the Hocum patient. And this is descending aorta. For the short axis view, we just rotate the probe 90 degrees to the patient's left. The probe should be placed in the same manner. We just rotate from the right shoulder, the marker of the probe, toward the left shoulder, and the axis will be changed. Now the heart is cut down on the slice in the short axis. Short axis has 3 waves. So if you can see that we have, our probe was like this, and now we have shifted toward the left shoulder, and we will see the heart like this. This is the LV, and this is the RV, and this is the septum. The short axis view has three level. We can look the heart in the short axis in the basal level, in the mid papillary muscle level, and the apex level, which give us very good information about the structures which we are looking here. And so if you can see that this is the mid papillary view, this is the papillary muscles, this is the interventricular septum, and this is the RV. In the level of the base of the heart, we can look for the mitral valve. You can see this is the mitral valve. If we move more superiorly toward the base of the heart, we can also look for the aortic valve, which will look here like a, by the three leaflets, like a sign of the Mercedes-Benz car. And we can appreciate here that as our patient has any bicuspid aortic valve or tricuspid, so we can see in this view easily. This is schematic diagram of the sign, the same view. So to make it more easy, so we have three waves level of this parasternal short axis view. This is the apical level. This is the this is the mid papillary level. This is the mitral valve level, and this is the aortic level. If we go further away from toward the apex, we will see the apical view of the heart, which is very good and give you the estimations about the movement in of the apex of the heart. Then apical four-chamber view. In the apical four-chamber view, we just take our probe and put in the apex of the heart, and the marker should be toward the left shoulder, as was in the short axis view. We can see here there will be four chamber of the heart present. You can see that this is the LV, this is the RV, this is the RA, and this is the LA. As I have told you earlier, this view will be looked for us. Then the subxipate view, we just probe, put our probe in the subxipate position. The marker should be toward the left of the patient, and it can give us this view, the liver, and after below the liver there will be right ventricle, right atrium, left ventricle, mitral valve, and left atrium. If we rotate the probe 90-degree clockwise, we will see inferior vena cava as well, which will give us the status of the filling of the IVC. We can estimate the volume status of the patient in this view as well. So to look for the pericardial effusion, the subxipate view is very excellent view. In emergency situations, we can just put our probe over here and we look for the pericardial effusion, and it will be very visible. If you look here, this is the effusion around the RV. This is the liver, and this is of course the effusion, and this is the RV which has been compressed by the effusion. In the pericardial tamponade, I will also tell about this a little bit more. We can see that it compressed the RV completely in diastolic phase, and it is completely collapsed. And this is the effusion around the RV. So if we look furthermore, it is a parasternal long axis view. I have told you that this is a descending aorta. So now we are in the long axis parasternal view. How to differentiate between the pleural effusion and pericardial effusions? It is we have a marker over here. It is a descending aorta and long parasternal long axis view. If the effusion is in front of the descending aorta, it will be pericardial effusion. If it is posterior to the descending aorta, it will be pleural effusion. So do not mimic and do not make pleural effusion to be considered a pericardial effusion. So this is the marker. We should look for the descending aorta and then decide what we have got there. this is another view of pericardial effusion and pleural effusion together. This is, you can see this is a streak of the pericardium, and this is the effusion over here, and this is the pleural effusion. At the same time, both can be present in the same patient. This is the effusion, and this is the pleural effusion. This is the pericardial, and this is the pleural. So now, how to calculate and how to say that the effusion is small, moderate, large, trivial. If it is because it is measured in the centimeter, if it is 1 centimeter, less than 1 centimeter, it is about 50 to 100 ml and is mild. And above the 2 centimeter, which is 20 mm, it means that is a massive effusion, large effusion more than 500 cc, and between is the moderate effusion. So we just measure the amount, and then we can, for example, we will measure from here to here. If it is about below the 1 centimeter, it is normal. It is more than 2 centimeter, it is a massive effusion. So we should also be able to look for the hemodynamic consequences, that if a effusion is present, so is it causing any hemodynamic instability in the patient or not? Because this is on our end, it is important to decide for the patient what should we do. Should we place a drain? Should we place a pectoral drain? Should we remove it or not? So we should look for the hemodynamic consequences according to the effusion, then we will decide. So things to look for will be RA, systolic collapse, RV, diastolic collapse, IVC, plethora. These three things should be looked for to decide the hemodynamic consequences of the patient having pericardial effusions. So if there is a massive effusion, the RA will be collapsed during systole. You can see that the mitral valve has closed in this view. It is a apical 4-chamber view, and this is the RA, and the RA has been collapsed here, bulging over here toward inside, and this is the effusion. So it means that it has a significant effusion in this patient, and this patient may be compromised hemodynamically. And of course, this is the RV diastolic collapse. In the diastole phase, if you see that the mitral valve has been closed, open here, so it is the filling phase, and we see that the RV has been collapsed. So RV collapse in diastolic phase. And then you can see another view of diastolic collapse of the RV. IVC plethora. Plethoric IVC means that normally the IVC will change its diameter between inspiration and expiration. So if it is constant and not moving at all, so we will call it the plethoric IVC, which is a good indicator of telling us that the pericardial effusion is significant and should we take an action. The opposite is also true. If you see that the IVC is collapsible, just if you we are seeing here that with each inspiration and expiration, it is changing its size and diameter. So it means that there is no significant hemodynamic compromise of the patient, so we can take it easy and go away. So measurement of inferior vena cava, we measure it for the fluid status, for changes with the respiration, and we can calculate the caval index to look for the preload reserve, that our patient have the reserve to make it more load or not. So we will just take our probe across the IVC and we will push the button of M mode, and we will this is the inspiration and expiration phase. We will measure this length and this length, and then we will have a formula that the maximum expiratory IVC diameter, this is the maximum diameter in the expiration, and this is the minimum in expirations. We will minus the maximum from the minimum and divide by the maximum. That will give us the caval index. If it is the distance IVC diameter, if it is we will look for the three things after to calculate the status of the fluid. Itself the size of the IVC, caval index, and we can estimate the CVP around the patient, that how much it would be. If the caval index is more than 50% and the IVC diameter is 1.5 or less than 1.5 centimeter, it means that our patient is empty, and it's about the CVP should be round about centimeter.
सेंटीमीटर में कौन सा है?
ये IBC का maximum. Normal should be between the 1.5 to 2.5, and it means that the cavity length is more than 50. The CVP around about this. If it is below the 50, the CVP is very high, and if it is dilated IVC, as I have shown you in the previous slide in the plethoric IVC, it means that the patient CVP is very high and no little change in the caval index. And if it is more than 2.5 and no changes in the caval index, that means that the CVP is more than 20. Now, the ejection fraction, which is very important for us to look. There are many methods that we are measuring the ejection fractions of the LV and RV. There are eyeballing method, which is a gold standard. There is some article they are saying that we can use the eyeballing ejection fraction, but it should the person who is going to estimate the ejection fraction from the eyeballing should have enough experience to look for the contractility of and the diameter of the contraction of the LV at the time of diastole and the systole, and they can estimate that how far it is moving, and they will tell us that the ejection fraction should be around that much. If you look here, this is the mitral valve, and mitral valve is slapping against the interventricular septum. If it is slapping very well toward and go toward the interventricular septum, it means that the contractions of the IVS is very good, and it will be the ejection fraction should be more than 50%. If it is not moving that much, they will say that the ejection fraction of as you looking here, it might be 30 to 50% moderately depressed, and if it is not moving at all, and the diameter is very huge in the LV, and the reduced motion of the mitral valve, so it is a poorly depressed LV below the 30%. Of course, there is other methods which I am going to discuss here. The other is using EPSS point and E point septal separation. E point septal separation is a method that we use, and we look for the anterior leaflet of the mitral valve and the interventricular septum, that how far they are separating from each other in every beat. As I told you, it will be very difficult to look and say about this, take this decision on just looking to the echo. So there comes the beauty of M mode. M mode will tell us that how far this movement toward the IVC of the anterior leaflet ML is taking place. We just put our line of the M mode across the leaflets of the mitral valve, and we just put the M mode button, and it will give us very beautiful view of this like this. So this is E point and this is A. Actually, every single time the mitral valve is moving twice. If you notice here, in every beat, the mitral valve is moving twice. If you see here, this is the E movement, which is a passive filling of the LV. So mitral valve will be open toward the interventricular septum, and there after that it is the coming of arterial kick, and it will again slap the mitral valve toward the interventricular septum. So this is why we are having two spikes of the mitral valve, of the AML of the mitral valve. This is the interventricular septum. This is the now we will measure the space between the interventricular septum and the AML. So we can see that the separations of the AML from the interventricular septum here is 11.9 mm. If it is below the 7 mm, it is normal. So we can say that ejection fraction is normal above 50%. But if it is more than 10%, it means that LV has dysfunction. It is not a good LV. You can see here it is more than 17.8 mm, very poor LV. There are some false predictor of cardiac function. AR and MS can take this E point septal separation misleading, because the air will push the mitral valve back toward the annulus, so it will give us false estimation. So we should look, when we are using the E point septal separation, we should look for the AR and AMS, because the movement of in the MS, the movement of the AML should be restricted, so it will not go far away toward the interventricular septum. So this will be not good to use E point septal separation in these situations. Again, there is a fractional shortening. So we have seen in our echo report, they have mentioned fractional shortening, and it can give us the rough idea of the ejection fraction of the patients. Actually, fractional separations in the parasternal long axis sweep, we just put our M mode across the leaflets of the mitral valve, and we will have this view. Then we will measure in the systole and the diastole the amount between the how far the LV has been open in diastole and in the systole. The diameter will be taken in the M mode, and then this is the systolic diameter and this is the diastolic diameter. And after taking these measurement, so LV fractional shortening should be equal to the LV internal diameter dimensions minus the systolic dimension divided by diastolic dimension times hundreds. It will give us the estimations of the ejection, the fractional shortening. For the male should be 50%, 25%, and the female should be 27%. So it is a normal ejection fractions. We can also calculate ejection fraction from the fractional shortening by multiplying the fractional shortening Fs by 2. It will give us the ejection fractions. For example, this male has a 25% of fractional shortening of the LV. So we multiply it 2 times, it is 50%. So we can say that the ejection fraction should be 50% in this patient. And of course, there is a Simpson biplane method for the calculation of ejection fractions. Actually, it is the area and volume method. We calculate, we take, it is the apical 2-chamber and 4-chamber view. We visualize the LV and we start measuring of the LV area from the tip of the annulus of the mitral valve and making our cursor a long way to encircle all the LV in exclusion of the papillary muscles and the trabeculations in the systole and meanwhile in the diastole. So it will give us the area of the LV. So diastolic volume or area minus systolic volume or area divided by diastolic times 100 will give us the ejection fractions by the method of biplane or desk method of the ejection fraction. This is useful when there are some abnormal wall motion abnormality presents and we are not able to calculate the exact ejection fraction. Then we use this method, and it is very good and accurate method with very little mistakes. This is the same procedure I have explained to you in the diastole, now in the systole, and then we calculate and it will give us the ejection fractions. Another important topic is diastolic dysfunction. It is very important for us to look for the diastole. In diastolic dysfunction, we take our pulse wave or continuous Doppler. We will make a parasternal long axis apical view, and across the mitral valve, we will put our pulse wave Doppler, not M mode, pulse wave Doppler, and then we will give a volume size about 1 to 3 mm sample volume between the mitral leaflet tips. And after that, we will push the pulse wave and it will give us this beautiful picture. It is very difficult to, if you see, you will be not able to say what is going on here. Actually, it is the closure and opening of the mitral leaflet. as I have shown the previous picture, that was E and that is A. E is passive filling of the LV and A is the arterial kick. So these two peaks should be measured. If you see here, the machine already gave us the value, that the E value volume is 108.47 centimeter per second, the velocity of the pressure at this point. At the 2, which is arterial kick, is 62 centimeter per second. So this is A and this is EA, and to conclude the diastolic function of the LV, it should be we calculate the EA ratio, which I have given in our report. If you have noticed that they mention E over E, or E prime over E prime, and A over A, the ratio when there is a the A point is peaked in A, it is a normal. We say that the diastolic function is normal and there is no other problem in this patient regarding the diastole. If the A, the arterial kick, has been more than the E, if you see in this picture that the A point is below than the A, it means this is impaired LV diastolic function. It is not normal. Then a stage come onward and we said pseudo-normal, because the A again get more than A. So this picture looks similar to this one, but it is a pseudo-normal picture, because in this stage the E point has been more because the ventricle has got stuffed and the passive filling pressure is very high. So when the mitral valve open, the volume rushes toward the LV, and zero compliance of the LV, the pressure of the passive filling has been increased. It's not because of the compliance, it's because of the stiffness, and it will give little area to compensate the volume and the passive filling. So this is why it is going to be very high than arterial kick. So now there is a question: how we will be able to know that it's a pseudo-normal and it's not normal? There comes Valsalva maneuver. We will ask the patient to take deep inspiration and hold it. This will convert to there will be a changing in this pseudo-normal, and the arterial kick will be increased again, because now the volume should be decreased, and we will be able to say that it is a pseudo-normal. It will be returned to the normal situation. Then comes the restrictive, when the E is very, very high than A. Even sometimes A is not visible in this patient. The restrictive pattern is divided by the two. As we know that we have 4 types of diastolic dysfunction: grade 1, 2, 3, and 4. The venas which are impaired, the A is more than E. The pseudo-normal is in grade 2, and grade 3 and grade 4 comes to the restrictive pattern, which is the E point will be more high than the A arterial kick. So we will ask the patient to again for the Valsalva maneuver. If it's a little change, it will be grade 3. If there is no change, it will be grade 4. So differentiations of the pseudo-normal, normal, and severe restriction has many modalities which is available in the echo machine: tissue Doppler, deceleration time, isovolumetric relaxation time, pulmonary venous flow, and EA ratio response to Valsalva. As I have mentioned this method already, now I am going to talk about the TDI, tissue Doppler imaging. So in the same manner, we just put our pulse wave Doppler in the septal annulus level, and we will the volume size now is 5 to 10 mm of the sample volume. Before was 3 mm, because we have increased the volume size to look for the the motion of the leaflet and the leaflet in the septum, to make it sure that how stiff is it. And then we will have this picture. This is the septal movement. Again, this is the E prime. Now now it's E prime. That was the pulse and continuous wave Doppler, and this is the TDI, tissue Doppler imaging. That was passive filling E, and it is again passive filling, but it is E prime, and its radial cake, it is A prime. So E prime should be more than 8.10 centimeter per second. If we are looking for the septal annulus, and if we are looking for the lateral annulus, then it should be more than 12 centimeter. It is considered normal. So we are confirming that the normal, pseudo-normal, and all these things by the TDI imaging. So if the E, our E prime reflects the left ventricular and diastolic pressures. Normal ratio should be less than 8. If it is more than 15, it is considered that the LV pressure at the end of diastole has been increased, which is an indicator of telling us that the patient has a diastolic dysfunction. So there is a summary: the EA ratio, the normal, the impaired, pseudo-normal, and restrictive, and also the in our E prime ratio, normal, it is a moderate, and it is a severe. LV and diastolic pressure has been increased, and restrictive are grade 4 diastolic dysfunction. I think so. Now the regional wall motion abnormalities. I hope that I'm not getting you people bored by this lecture. It is a little bit lengthy, but I have tried my best to make it interesting and easy. This is a very crucial topic regarding to us as we do coronary surgeries. So it is important to look for the which region has been involved. The echo will tell us about the ischemia even before the ECG, because the moment the myocardium has been insulted, it will show a motion abnormality. Even it can tell us before the ECG, and it can tell us before the cardiac markers. So it is a very good tool, and I find it is very interesting, and it is very important. So this is why I put it here. So in the wall motion abnormality, first of all, we should look for the differential diagnosis, which is going on. Ongoing ischemia. Is there ischemia? Because of ischemia, there is a abnormality of the motion. Is there prior infarction? Is there any myocarditis? Is there prior surgery, especially valvular surgery? Is there any bundle branch block? Is there any pre-excitation accessory pathway in the conduction system? And of course, the stress cardiomyopathy. This should be present in our mind, and we will look for these things to conclude that what is going on. So ischemic regional wall motion abnormality should be visualized in, I have told you that it is very important, and it will tell us before the ECG and the markers. Now this is very important slide to know and conclude the regions. This is the vascular supply, and we should know that which region in which wall is supplied by which artery, and these are the views which we know that this is the apical 4-chamber view. We have now familiar what is apical 4-chamber view, and if you see that this portion of the RV is solely supplied by the RCA, this is the color coding over here. This septum portion, basal septum portion, is also supplied by the RCA. This portion in the 4 apical chamber view I am talking right now, this is by the LAD and the RCA together, and this is the apical septum is supplied by LAD solely, and this portion is supplied by LAD and the circumflex artery. So you should make yourself familiar and practice that the which region is supplied by which artery, not according to the our knowledge, but according to the view of the echocardiography which we are making over there on the machine. The 2-chamber view, this is the RCA, and this will be entirely LAD. And of course this is again RCA and circumflex, and this is the LAD, and this is the RCA. And this is the short axis views, the apical view, the mid view, and the base view. So in the parasternal long axis view, this is the we see this is anterior lateral. This is the septum, which is supplied by the LAD, and this is the inferior wall supplied by the RCA. This is the parasternal short axis view. This is the septum over here, which is supplied by the base is supplied by the RCA, and toward the interior and the apex is supplied by the LAD. This is the lateral. This is the basal wall, and this is the lateral wall. This is the apical four-chamber view, just to make familiar that which wall is which. This is anterior lateral, which is supplied by the circumflex artery. This is the septum, which will be supplied by the RCA. Here supplied by the RCA and LAD, and there will be supplied by the LAD. And this entire portion will be supplied by the RCA. This is the apical two-chamber view. Now, to look for the classic lesions, if the lesion is present in the LAD, so how it will be look on the echocardiography. So for the septum, it is a you can see that this is a short axis view at the level of the mid papillary level, and this is the septum. This is the RV, and this is the septum, and this is this portion of the supplied by the LAD. So it's now not moving well. Actually, I don't have the video to show you the exact movement of this, but trust me, believe me that I am telling you the truth. This portion is not moving for sake of knowledge. Okay? This is another view. This portion, which is the septum, is not moving. So we are concluding that this portion is supplied by the LAD, so there is a lesion in the LAD. This is another classic apical four-chamber view. The entire septum and the apex is not moving. So we know that it is supplied by the LAD, and of course the base of the septum is supplied by the RCA as well. So it may be also involved in this patient. This is another example. Entire apical and septum is not moving. The RCA, we know that the RCA is supplying the basal septum over here. So in short axis view, it is not moving there. This is another example in the RCA. This short axis view, this is the inferior wall of the myocardium is not moving here. And this is the parasternal long axis view. You can see this the lateral valve of the inferior lateral valve is not moving over here. The circumflex lesions, you can look for the lateral side in the short axis view. This portion will be not moving, so you can conclude this is the problem in the circumflex artery. And it is the apical four-chamber view. You can see this region will be not moving. And of course, then we have to give the correlation with the ECG finding, and do not forget your differentials, which I have mentioned earlier. So that was all about the importance of the LV. Now it's time to give some importance to the RV, which is very important as well. It's a forgotten ventricle, forgotten chamber, but we are not going to forget this chamber. So you are familiar, you have seen and you have read that the TAPC, RV, STDI, and what is the definition and interpretations of the how they calculate it. As for the basic RV assessment, we are going to look for the RV size, the shape, and RV function. For the function, we use TAPC, free wall motion, and cavity size, and of course RV STDI as well. And then we can look for the septal kinetics, RV free wall thickness, and tricuspid agitation. These all things will give us the idea about the RV assessment, and will tell us in which stage our RV is present. So the RV size in the apical four-chamber view, the normal RV is less than 2/3 of the LV. If you just look for the size, it should be less than 2/3 of the LV. So it's a normal size. If it is comparable, is equal size to the RV and LV, it is a moderate dilated RV. and if it is dilated in the RV, it is a dilated RV just by the seeing it. You can see that this is the RV and this is the LV. It is smaller than this one, maybe more than 2/3 smaller than LV. So it's a normal RV. If you can appreciate, this RV and LV are almost the same size. So it is a modulated dilated RV. And in this view, you can see this is severely dilation of the RV. It is taking over the apex of the heart as well. Normally the apex is taken by the LV, but whenever the RV takes the part of the apex, it means the RV has been dilated too much. Then there is a rule of third in the parasternal long axis view. The size of the RV, aorta, and the LA should be same. It means it is normal. If it is a difference, if the size of the RV is increased in this view, then we can look for other views and to calculate this, the size has been increased. We can also measure from the valve of the free valve toward the septum, and we can say as they are doing down there on the floor. They are just measuring the RV from here to here, and they tell us that the RV is that amount of area. So the shape should be crescent shape. If it is dilated, it could be circular or ovoid. The shape can also give us the idea. This is a normal shape, which is the crescent shape. You can see that the ovoid shape of the RV dilated. This is the circular shape of the RV. This is the septum. This is short axis view. You can see this is a circular, so it is a dilated RV. So as I mentioned before, that in this view, this is the normal one. This is the RV. This is the LV. And this view, the RV is taking over the apex, which is mean it is very enlarged RV. So RV function. For the RV function, we use TAPSE, tricuspid annular line systolic excursion, and free wall motion abnormality, and of course the TDI mode. Tricuspid annular plan systolic excursion has been found that it is a very good estimations of the movement. Actually, the long axis movement of the RV is going to be assessed by the TAPSE. Longitudinal vertical movement of the lateral TV annulus. It will be seen in the apical port chamber view, and we can quantitative in the M mode, and we can measure vertically as well. Normal TAPSE is more than 16 mm. If it is less than 16, it is abnormal. The RV function is uncompromised. So how to calculate? We just take apical 4 view, 4 chamber view, and we put our M mode cursor across the tricuspid valve lateral annulus, and then we press the M mode. And from here, that we see the movement of the tricuspid valve. This will tell us the amount, and the machine will give you automatically calculation that how far this movement has been going. This is actually quantitative method. This is also eyeballing method on the RV function evaluation. You can see on your eye that the motion is very good, so you can estimate and say that the RV function is well. If you see in this patient, the movement of the valve is very sluggish compared to the previous one, which is very good. In this patient, the calculation is 1.36 centimeter. So the TAPSE is about 13.6 mm, which is less than 16. So it means the RV of this patient is not good, abnormal TAPSE, low ejection fraction of the RV. Then another is a free wall motion assessment to look for. we can see for the eyeballing the movement of the free wall. Of course, we can see the movement in the apical four-chamber view. Parasternal long axis view, the best view is the apical four-chamber view. And as we measure the LV function, the same we can do here. We can use fractional shortening. We can use biplan Simpson method, and all these which we have already discussed for the LV. This is a picture which is normal abnormal movement of the LV. RV. Septal kinetic also can give us the idea of the, because the septum is also part of the RV. It can tell us about the dyskinesia and all the septal flattening, which is very important concept in regarding to the overload and pressure load in the RV. If the pressures in the RV is increased, the septal will be flattening during systole toward the LV. If it is volume overload, the septum will be displaced toward the LV in the diastole. So this pay a crucial amount of time to look for the septal kinesis. As you can see here, this is the septum. This septum is not moving well, so there will be a problem in the RV. Flattening, as I told you, in systole, RV pressures overload, and in diastole, RV volume overload will be present. The septum is going toward the LV. You can see this is the short axis view. This is the septum, this is the LV, this is the RV. So in the diastole phase, the septum has been pushed toward the LV. It means the RV is volume overloaded. There is some problem in the RV regarding its function. And of course there is a hypertrophy. We can look for, we can measure it, we can, if it is below than 5 mm, it is normal. If it is more than 10 mm, strong is just chronic RV pathology. The free valve measurement, we just in the apical four-chamber view, we measure this amount, this length, and it will say about the size of the free wall of the LV. Of course, the tricuspid regurgitation can also tell us about the function of the RV in chronic patients. This is a picture of the tricuspid regurgitation. So I think this is it what we had today. Of course, there is a valvular echocardiography which will take further time, and it is beyond the scope of this presentation. I have already taken too much time.